And good afternoon, everyone. Welcome to our live webinar. Should say good afternoon for those of us who are here in Eastern Standard Time. Those of you who are further west in the US, good morning. And I understand we have some international colleagues joining us today, so perhaps it's even good evening. Thank you so much for taking time out of your busy days to join us for this webinar on practical tips and best evidence for integrating Harvey throughout health professions education. A little bit of housekeeping before we get underway. Just a quick reminder, I'd ask everyone to keep their microphones muted throughout the presentation. If you'd like to communicate with your colleagues who are online in an informal way, please use the chat function here on Zoom. But I'd ask that you save any questions for the panel till the end by typing those into the separate Q&A function. If you notice, there are separate buttons along your control bar. So again, because the chat may be very active and we would miss questions flying through, it'd be a lot of scrolling to keep up, we will check the Q&A function to answer your questions at the end of the presentations by the respective panelists. You will receive, probably by the end of this week, a follow-up email from Laerdal that will include a recording, a link to the recording of this session, as well as some contact information for your local Laerdal representative. And we will share our email contact at the end of the presentation for any follow-up. Just to introduce those of us on the panel, for those of you who don't know me, I'm Ross Scalise. I'm a general internist by training and an associate professor of medicine at the University of Miami. I'm also director of educational technology development at the Gordon Center for Simulation and Innovation in Medical Education, and I will be leading the panel discussion today. But I'm very pleased to be joined by two of my esteemed colleagues, longtime collaborators in our simulation education work. Dr. Nina Multack is professor and an associate dean at the University of Florida, where she is director of the School of Physician Assistant Studies in the College of Medicine. Those of you involved in simulation for physician assistant education may know Nina, her work at the IMSH. She leads the special interest group on physician assistant education there. Dr. Jeffrey Groom will also be well known to many of you. He was one of the co-chairs of this past year's very successful IMSH meeting. He is professor of clinical anesthesiology nursing and director for special projects at SHARE, our simulation hospital for advancing research and education at the School of Nursing and Health Studies, also here at the University of Miami. Just some quick disclosures. Dr. Groom and I both work for the University of Miami, which does produce and distribute Harvey and UMedic. But we receive no compensation related to the distribution of these educational systems, either by the university or Laerdal Medical or other interests. Nina has no conflicts of interest to disclose, and we would like to acknowledge our partners at Laerdal Medical, thank them for hosting this and bringing us all together for this presentation. We have several learning objectives that we'd like to accomplish by the end of this webinar. First is to describe the uses of Harvey for teaching and assessment of essential competencies, whether you're in a medical, physician assistant, or nursing and health sciences education program. We'll outline some steps for how to integrate Harvey into the curricula at your different programs. And all along the way, we'll be citing some evidence of Harvey's educational effectiveness in different learner populations across the health professions. So before we get underway with the formal presentation, we'd like to just know who's in the audience. So we'll be using the polling function here on Zoom. I'd like you to choose, you may cross domains here, but I'd ask you to choose your main affiliation. Are you involved with physician education, physician assistant, nursing? Perhaps you're a basic science educator, or other educational specialists. Perhaps you're approaching this directly from you're in charge of simulation or technology operations at your institution. We have 1 vote for number 8, which is interesting. Let's see if we can get a few more in. We'll get at least a 50% response rate here. It's good. We have a very broad representation across different professions. Let's give it a few more seconds. All right, survey says. All right, so we have a bunch of others. Perhaps we will be able to parse that out. Later on, Jeff in his presentation will ask about some of the other allied health professions. But we do have about 15% who are involved in physician education, another 6% for physician assistant, 12% for nursing. We have quite a few who are education specialists, that's more than 20% of the group. And another 12% involved in technology or simulation per se. Wonderful. And since we are going to be focusing on some specific educational technology, we also wanted just to know who is familiar with Harvey and or UMedic, which, as you can see from the little photo here, is our e-learning programs. Did you use it in the past, perhaps at a different institution? Are you currently using it, but mostly for teaching or for assessment? Maybe you've heard about it and that's why you're joining us today. You're thinking about it for future use. I'm also very interested to know if anyone has experience, if your main exposure to Harvey was actually when you were on the learner side rather than on the educator side. Okay, let's see if we can get at least half of our audience to respond. Hopefully you're getting a little pop-up window. That is a floating window. So we will be asking some polling questions later on in the presentation. If that's covering up the slide, you can just move that off to the side. All right, and let's see. Survey says. All right, so some people have used it in the past. A large number, 40% or more, are thinking about it for future use. Okay, we did have someone who has experience on the learner side. That's wonderful. A third are using it mostly for teaching, but we do have 10% whose main use would be for assessment. And we will touch on all of these uses for Harvey and UMedic throughout our presentation. So for those of you who aren't that familiar with it, just a little bit of history. Harvey made its debut at the American Heart Association scientific meeting in 1968. And therefore is the longest continuous computer-enhanced mannequin simulator in health professions education, now more than 50 years. Obviously, it's changed a lot. You can see this historic photo. Back at the AHA meeting in 1968, one mannequin could only simulate a single disease, and Dr. Gordon had 3 prototypes that were available at that time. Then this upper left photo, you can see what one of those prototype mannequins looked like. It was a massive piece of equipment. All of the pulses were generated with rods and pulleys and mechanics down inside the cabinet, weighed over 500 pounds. Moving down a little bit to the bottom left, you can see where then we did have a multi-disease Harvey, could simulate more than one condition. But then there was a big quantum leap forward where we moved to all digital technology, the upper right. At that point, Harvey could simulate 30 different conditions. And now the lower right, we have next generation Harvey, our latest version, which you can recognize by his very sharp little outfit. Now, it's not just these cosmetic differences and the massive weight loss. Harvey is, of course, much more portable now. But under the hood, many enhancements have been made recently. Harvey can simulate just about any finding you can think of related to the cardiac exam and some pulmonary findings as well. I think sometimes people think Harvey is just a heart sound simulator, but in fact, you can get the full physical exam findings or patient assessment findings with venous and arterial pulses, chest wall movements, of course, auscultatory findings in all of the classic auscultatory zones, but murmurs will radiate to the carotids or the axilla and so forth as is appropriate. And we do have from the digital versions of Harvey forward, the inclusion of pulmonary auscultation findings as well. The latest generation of Harvey can now simulate 50 different patient scenarios. On the left, we have just a few excerpts from the learner manual, which details all of the many findings in each condition. And this little wall chart here shows that there are many thousands of findings available in Harvey. Harvey, of course, also comes with a complete curriculum. This is one of the distinguishing features of this as an educational system. And UMedic is the multimedia e-learning version of the Harvey curriculum, which you see comprises really complete assessment, starting with the history of the patient, of course, a lot of detail related to the physical findings, but then we present as well laboratory data, treatment, and so forth. A really comprehensive cardiology curriculum. Additional resources include the learner manual that I already referenced. There's also an instructor guide. One of the things that that Jeff and Nina will talk about is sometimes instructors feel like you have to be a cardiologist or a general internist to be able to teach this subject matter, and that's not true. Harvey is extremely user-friendly. To operate takes less than 5 minutes to learn, and in terms of the curricular content, with the help from the instructor guide, educators can be up and running with Harvey in their programs very, very quickly. I'll give you some excerpts from the instructor guide as we go through the presentation. Now, you noticed from one of our learning objectives that we're going to try to cite evidence of Harvey's effectiveness. So it's not just, hey, here's this great simulator, why don't you try it? Having been around more than 50 years, Harvey is probably one of the best studied simulators in health professions education. One thing that a very important project that those of us at the Gordon Center have been involved with and some of our consortium colleagues has been the BEME initiative. Don't feel bad if you've never heard of BEME, which stands for Best Evidence Medical Education Collaboration, but you can think of it as the health professions educational analog to EBM, evidence-based medicine, which I'm sure you're all very familiar with. And just like the Cochrane collaboration embarks on systematic reviews and meta-analyses of the clinical medicine literature, so the BEME Collaborative undertook about 2 decades ago a series of systematic reviews to look at and to try to improve the quality of health professions educational research. We led the first topic review group, which was to answer this question: what are the features and uses of high fidelity medical simulations that lead to effective learning? I mentioned that the BEME Collaborative has been around for about 2 decades. It began just before the turn of the millennium, late 90s, early 2000s, and that was exactly at the time that the use of simulation was taking off around the world. So this seemed a very timely and important question to ask for the many, many programs that were starting to adopt simulation. I'm proud to have been part of this work, which has now become one of the, or actually is the most cited reference related to simulation-based health professions education in the literature. I just did a quick Google Scholar search the other night, and we currently had more than 3,400 citations to this work. Why do I think that this has been so heavily cited? It's because we distilled from the available literature at that time those features that seemed to work. One of our inclusion criteria for this review was that the studies had to have shown some positive educational outcomes. And then we distilled in an iterative manner what were those features that these authors were talking about. And here you can see the list of the top 10 most commonly cited features. These will be of no surprise to anyone. The fact that feedback is important. The importance of offering opportunities for repetitive practice. importance of curriculum integration, and so forth. And I'd like to use this BME framework to touch upon these features as they relate to practical tips for how you can integrate Harvey into your educational programs. Starting at the bottom, validity of the simulator here referred to the face validity, how realistic it was. And as I mentioned, Harvey, probably more than any other simulator in this domain, can simulate a wealth of cardiac and pulmonary findings very, very realistically. But then ticking up, I'm going to kind of work backwards up this list. This is not in order of importance, but the order and frequency in with which these were cited explicitly in the articles that we included in our review. It doesn't mean that they are not as important just because they're lower on the list. And in fact, the next item up was the importance of defining your outcomes from the outset. We are operating, after all, in the outcomes-based educational paradigm now. And so it's very important that you explicitly determine what results you want to achieve at the end of your educational program. That can be on a micro level, like after one unit of instruction or one course, or it can be broader educational outcomes, like your institutional educational objectives. Many of those, I suspect, relate to even higher level, perhaps national or regulatory outcomes. Within medical education, physician training, with which I'm most involved, we are focusing lately on, you've probably heard of EPAs, Entrustable Professional Activities. These are a list of 13 core competencies, or actually these are activities that require several different competencies to be brought to bear in order to accomplish them on a day-to-day. And if you look, I know this is a busy slide, but the first several of the EPAs, gathering a history and performing a physical exam, prioritizing a differential diagnosis following a clinical encounter, recommending and interpreting common diagnostic and screening tests, entering and discussing orders and prescriptions, documenting a clinical encounter. Almost every one of these things one could contextualize in a Harvey patient encounter and therefore teach and or assess many of the core EPAs. I am sure in your health professions, and I know that Nina and Jeff are going to talk about the accreditation requirements in their respective specialties, but it's very important that you relate your activities, your educational activities, whether they involve Harvey or otherwise, to some explicitly defined outcomes. Another BME feature was identified as the importance of individualizing for different learning strategies. We know that not every learner learns best in the same way. Some do quite well in large group, instructor-led, lecture-type settings. Others need a more intimate, small group learning environment. Still, other students may prefer not to have the presence of the instructor right there. They might find that a little bit intimidating, feel pressured for time, and so forth. So we do quite a bit of our instruction in small groups where it's peer-guided learning. And yet other students prefer self-regulated learning on an individual basis. If you can incorporate multiple or accommodate different learning styles, you are more likely to be effective. And you can see here that we indeed do use a blended approach with a mix of different learning opportunities. You'll also notice that I italicized here, emphasized active learning strategies, especially if, for whatever reason, it may be logistical, numbers of learners, etc. If you're doing a large amount of lecture-based, instructor-led training, be sure to try to incorporate active learning strategies. So I'm going to cite a number of studies that documented that Harvey is very effective. One study, it's pretty much the only one that I'm aware of in the literature, that was actually a negative study where they did not realize very significant learning gains, was when it was a large group, instructor-focused type of setting. where the instructor was probably up at the front of the room saying, so everybody's hearing that third heart sound, right? And the students would dutifully nod, oh yes, 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 but they weren't really learning it. So what we try to do, even in our large group settings, is try to be active, call on people. What do you hear? Could you describe the cadence of that extra heart sound? Or something very simple like we're using here in this webinar with a large number of people online with us, an audience response system, very effective way to engage your learners and make it more of an active experience. The wealth of different conditions that Harvey can simulate suits it very well to accomplishing this other BEAMI feature, which is to offer as many different variations or clinical examples of different patient types and conditions that they might encounter. You'll notice in the previous slide where I said we do a fair amount of our instruction in small group peer guided or independent learning. How that can be accomplished very effectively is we situate right next to Harvey. You can see in this left-hand panel, we have the computer right there with the UMedic programs loaded, and those use active learning techniques, multiple choice questions with immediate feedback and so forth. So in that way, I don't have to be there teaching every session myself. The professor doesn't have to be in the room. Students can do this quite effectively on their own. Of course, it's important that we match the simulator use to the learner's level. Just because Harvey can simulate some very complex congenital cardiac abnormalities does not mean that that would be appropriate for, say, a first-year medical student. So in fact, in a very deliberate fashion, we have mapped out what our expectations are, even related to the same finding. In this little example I show you here, you can take just a fourth heart sound as a common cardiac acoustic event. For first-year medical students, we would only expect that they identify that. I can hear that fourth heart sound. I know that that's a fourth heart sound. Second-year medical students, which have now been introduced to pathophysiology, should be able to correlate that sound to what must be going on in the heart to produce that. Third-year medical students are now in their clinical phase, and so we would expect them to generate a differential diagnosis based on that. Who among the patients that you see on the medicine wards or in the clinic would you expect to have a fourth heart sound? And you can take this right across the educational continuum. We train internal medicine, family medicine, pediatrics residents, as well as even cardiology fellows, and we would have expectations for the tasks that they could accomplish according to their educational level. A very, very important feature is the integration of any simulation into your curriculum. It can't be something that's optional or just for fun. Hey, check out this Harvey that we just got. It's great, it can simulate 50 different conditions. Why don't you go check it out? Our learners just have too much on their plates. So we have to protect time, carve out in a very systematic way, where does the use of this simulation technology fit into the overall curriculum? An example that I like to cite is that of the British Heart Foundation and Harvey in the United Kingdom. Back more than 20 years ago, the British Heart Foundation thought so much about Harvey that they donated a simulator to every medical school in that country. At that time, there were 27 medical schools in the UK. They went back a year or two later to see how were these schools using this gift. Some put their Harvey in a locked room with a plaque outside, or maybe behind a nice window display with a spotlight shining on it, courtesy of the British Heart Foundation. But they were too afraid to use this expensive piece of equipment. Somebody might damage it. And it was sitting idle, basically. Other places had integrated it into their curriculum. They were requiring that students went on a regular basis to work with Harvey. They were tracking learner usage. Very importantly, we know assessment drives learning. So they were actually testing those outcomes to see if they were achieved. And sure enough, those institutions were realizing very remarkable gains, not only in knowledge, but also in clinical skills, confidence, which is very important. Very effective way to do this is to use a curriculum blueprint and map where exactly you might use Harvey and or UMedic in your curriculum. This is a page right out of the instructor guide that comes with Harvey. Just a sample template for how you might integrate Harvey across a 4-year medical education program, as we have here in North America. You can see here we suggest, that in year 1, when they're learning normal physiology, just focus on normal in Harvey. And we use a blended approach. We do some large group instructor-led teaching and about equal amount of some small group or independent learning opportunities where they can go and practice on their own. As they progress, you see we then layer in progressively more difficult or complex conditions. So the main valvular abnormalities, for example, in 2nd year, once they've learned some physiology, pathophysiology. Again, a mix of some large group lectures with small group practice opportunities. You'll notice then as we progress across the curriculum, once they move into the clinical phase, we do less and less instructor-led and more of the time is spent in self-regulated learning. Again, how we can accomplish that is by using the accompanying curriculum package or the UMedic programs to stand in for the instructor and letting the students to do this on their own, such that in 4th year, when we offer a 4-week cardiology elective, students are doing almost all of the Harvey programs, and they're doing that independently. Here's just a detailed drilling down on a 1 week from that 4-week final year elective. I know it's a busy slide. I don't expect you to be able to read all of the fine print, but just look at the color coding. Things that are in yellow, you notice say CPS rounds. That stands for cardiopulmonary simulator. They always have a doctor's name after it because those are instructor-led. So a couple times a week, led by the instructor, they'll get a little presentation, in this case on mitral regurgitation, the next day on aortic stenosis, have a little review session later. But every day, you'll notice that there are white sessions where for an hour and a half or so, they meet in small groups, and we've laid out here which of the Harvey curriculum programs or UMedic programs we'd like them to go through on their own. Getting toward the end of the BME features, another important thing, obviously with any skills-based domain, you'd like to give them opportunities for repetitive and deliberate practice. These are 2 studies that we were involved with, looking at a subgroup of the BME articles. The pane on the left shows that there is a quantitative relationship between the amount of repetition, amount of practice that people have, and the magnitude of the learning gains. It's not strictly linear. You can see that if they only have an hour or less, or even up to 3 hours or so, they'll get modest gains. These are effect sizes here on the y-axis. This is looking at a number of different domains, not just cardiology clinical skills. But if you have more than 8 hours of practice, then you get very substantial gains. So it's almost a dose-response relationship here. In the pane on the right, this is a Harvey and UMedic specific study that we did a number of years ago, involving not only 4th year medical students at the University of Miami, but 4th year students at several other medical schools and internal medicine residents. PGY stands for postgraduate year 2 and 3. So senior internal medicine residents also participated. You can see very interestingly that at baseline, pre-testing, there was actually no significant difference in their abilities to recognize cardiac findings, et cetera. After training opportunities with Harvey and UMedic, the outside medical students really did not significantly improve. The line, the slope here is almost flat. But the 2 other groups, in green, the internal medicine residents, and in blue, our University of Miami students, very significantly improved, almost doubled their scores. And you see a very interesting thing. There's a trend, not statistically significantly different, but a trend toward the medical students actually outperforming the internal medicine residents, who clearly have much more clinical experience. But what's the difference? How much time they practiced. The outside medical students only had an hour or two with Harvey, whereas our residents on average practiced for about 10 hours, and our medical students practiced for about 16 hours. So clearly, giving opportunities for deliberate practice is very important. And last but certainly not least, we all know about the importance of providing feedback. This doesn't just happen on its own. You have to plan for it in advance. Okay? In some cases, this is built into the learning resources. Again, the Harvey curriculum poses questions and answers on the PowerPoint slides. The UMedic program has multiple choice questions built in with immediate feedback. So you can be doing this either in formative type of sessions where the instructor would observe and then debrief the student on how they did, or you can also use Harvey for more summative assessments and decision-making, such as passing and failing a given course or year of instruction. So Harvey has been used extensively, not only in our own institution, but elsewhere in OSCE's, Objective Structured Clinical Exams. It's just an example of a checklist that we provide in the instructor guide, which you could, of course, adapt to your own assessment purposes. And Harvey is not only used at the local institutional level, but in some cases at high stakes national levels. This center panel here, both of these actually are from the Royal College of Physicians of Canada, used Harvey in their national internal medicine oral board certification exam for about 10 years. Of course, finally, the million-dollar question in all of our simulation education is, do the skills or does the knowledge that they acquire in the simulation setting translate to real patient outcomes? There have been a number of studies that have demonstrated this, that the answer is yes, with Harvey and UMedic. More than 30 years ago, a landmark paper on the left, which was actually sponsored by a branch of the NIH, looked at multiple medical schools, 5 different schools across the US, and compared Harvey-trained students with those trained in the traditional way, just on the wards and in the clinic. And the simulator Harvey-trained students outperformed the traditionally trained students. More recently, about 10 years ago, at a number of medical schools in the Chicago area, some of our colleagues at Northwestern also looked at this. In blue, you have third-year medical students. In yellow, fourth-year medical students. The third years were trained with Harvey. You can see that at baseline, both groups fell below the MPS, the minimum passing standard that was set by an expert panel. But after training, the simulator group had very significant gains and were well above the MPS. And very importantly, this post-test in the middle bar was with the simulator. They also tested students, both groups, with real patients with cardiac findings. And again, you can see that there was no difference in the fourth-year medical students who had not been trained with Harvey, but the third-year medical students did significantly improve. The error bars are well above those of the untrained or traditionally trained students. So I will wrap up there and turn things over now to Nina. Thank you very much.
Thank you, Ross, and good morning, good afternoon, and good evening, all of you lovely attendees. We're so glad to have you with us today. As Ross so adeptly mentioned, there are a lot of things to consider when you implement Harvey and simulation-based cardiopulmonary education into your curriculum. But first, I'd like to take a moment and for us to do another poll. You see here on the slide the questions of the poll, and the polling question correlates to the number on the slide. So if you would be so kind to take a moment and select what your role is in PA education. Are you involved in the didactic or academic year, the clinical year, simulation-based education, administration, or other? Please enter your responses.
Have about a third in, although I know that the total number are not physician assistant educators, so I'll close the poll now.
Okay.
And results.
Well, there we go. It looks like, based on our results, approximately 58, well, not approximately, 58% of you all are involved in simulation-based education of PA students. And the next highest ranked response was other areas of PA education. And that's really important to know as we move forward. The next slide, please. For those of you who are not integrally familiar with PA training, I'd like to share that in the United States, we have 267 PA training programs. Most of them are approximately 2-year, 24 to 27 months in duration. Each of them is composed of 2 phases. The first phase, or approximately the first year, is a didactic phase or academic classroom phase. During the COVID pandemic, many of our PA training programs are using a hybrid approach, which certainly supports active learning, as well, as Ross mentioned. And the second year is comprised of clinical rotations. Each of the programs has approximately 30 to 75 students and are located geographically in academic health centers and small universities. And some PA programs that are at small universities will receive their simulation-based training at local institutions and share their resources. So depending on where the PA program is located, will determine the access to resources. And I'll spend a few moments talking about how we integrate the active learning components. But I also want to mention that PA training is competency driven. Each PA student must pass a certain set of competencies according to our national standards to move from one section of our training to another. On this slide, you'll see the blueprint from the National Commission for Certification of PAs. And what you'll see here are the areas and the percentages that all PAs must be competent and display competency in order to complete their PA training. And so this is the percentage that each of the PA training programs allocates to these domains. You see here under medical content, cardiovascular system has a 13% allocation, and pulmonary system 10%. This is a big chunk of the medical content category. And in the right chart, you see the task categories: history, taking and performing physical examination, and performing most likely diagnosis encompass more than 30% of the tasks that physician assistant students need to be competent in order to be practicing and caring for patients in a safe manner. So the utilization and implementation of cardiopulmonary education is really vital to a PA's success. Next slide, please. There are many ways that you can integrate Harvey into the PA curriculum, and if you're involved in onboarding a brand new PA program, or you're involved in implementing advanced and enhanced cardiopulmonary training using Harvey into an existing curriculum, you may have different considerations. I show here a slide with some options of how Harvey is commonly implemented in PA training. So during the first year, year 1, the didactic course, typically a few months into the PA training, we have history taking and physical diagnosis course. And the physical diagnosis course is a great way to start implementing Harvey. And as Ross mentioned, we use this in a scaffolding or a layering advancement of knowledge and skills. So here, different elements of Harvey's educational training program can be implemented across different courses. And in PA training, the students typically have all of the different active learning strategies mentioned by Ross earlier. We have large instructor-led groups. We have small instructor-led groups. We have students who are working together. And one of the earlier slides show a student went there on their own. We tend to find that when we set the standard for learning in each of these categories, instructor-led, small group-led, and student-led, students constantly ask for more slots to practice, and often will go back and access Harvey on their own. And so having access to Harvey at night and on the weekends at your institution is really a robust way. Some of the students are a little anxious to practice in larger groups and really like that added practice opportunity. And not as Ross mentioned, not only does assessment drive learning, but the enhanced practice opportunities really support increase in skills. You may think, how do we use it in the clinical year when we only see students once a month? Some institutions, during the clinical phase, every student has a 4 to 6 week clinical rotation. They come back to campus or have a virtual educational component to their post-rotation day. And there we integrate problem-based learning, case-based learning using Harvey, and we use this and scaffold the advanced components of the curriculum. Again, I would mention the instructor manual and the student manual that Ross mentioned earlier. These have components that are already predetermined of how one can scaffold the different content areas that would best meet the needs of student learners. Certainly, if you have students who are going to go into specialty cardiac areas, there are specialty focused cases out of those 50 cases that can be used to enhance individual student knowledge. Next slide, please. I mentioned a little earlier that we have to validate that our PA students, as well as the PAs, are competent. We love using Harvey to do that because we can verify that a student has progressed during each of the phases of the training program. During the first year, we have an end-of-year objective structured clinical examination, and so students must pass the cardiopulmonary component to advance to clinical rotations. And at the end of training, we have a summative assessment element, and here's another great way to validate your students' competency in terms of skills and knowledge. Why do we like to use Harvey as an evaluation tool? Well, the data quality is the same. Every student is subject to the same information when assessed. We also can use Harvey for remediation, and we found that there's not exactly one size fits all, and those of you who are familiar with competency-based education are keenly familiar with the fact that not all the students are progressing at your usual or anticipated rate, and having opportunities for remediation using Harvey has been a really valuable tool. Also, as all of you are keenly aware, the cost and the time and the puzzle that's associated with scheduling can be challenging, and Harvey in a convenient location really helps minimize the challenges associated with scheduling and time perspective. Thanks. Next slide, please. So how do we get our PA faculty on board, or those of you who teach PA students and would likely need the support of PA faculty? One of the things we talked about a lot is the progressive development of the student. We already have the manuals available and developed to assist you in developing the architecture that's best for your group of PA learners. Quantitative practice, access to Harvey is certainly key, and deciding your approach to problem-based learning. I think that with our virtual opportunities, we have such a variety of innovative ways to implement educational innovations that it's always hard just to pick one. And I think that Harvey is well suited for the innovation we're currently using during the pandemic. Lastly, on this slide, I'd like to mention faculty development. Many of you who are teaching PA students may or may not be experts in cardiology, but it's really fairly the steps to implement Harvey and the ability to program him to to teach the faculty to support your training of PA students is already developed for you. A number of years ago, there was a study done, probably about 20 years ago, among PA faculty, and it was noted that that PA faculty could use a little refresher using Harvey too. So before you embark on teaching your PA students, I would suggest some consideration of faculty development. Next slide, please. And about 10 years ago, 4 PA programs embarked on a multi-institutional study to use simulation to teach cardiopulmonary exam and diagnosis skills to PA students. And I will just refer you to these tables here. If you take a look at knowledge assessment, you see the 20 percentage point rise in a pre-test and a post-test settings. And the cardiac exam technique, we found an increase. We also found we were doing a pretty robust job training the skills themselves. And next slide, please. Finally, you can see some significant dramatic increases in the identification of total and key auscultatory findings, as well as diagnostic accuracy, which was significantly noted as a result. I will be we were pleased to see these significant findings, and with a sense of time consideration, I would like to pass the microphone to my colleague, Dr. Jeff Broom.
Thank you very much, Nina. We will start off with one more quick survey question and just ask, we've talked a little bit about medical students, PA students. Who might your other learners be? Whom are your primary other types of learners? And we can quickly get some feedback here. And Ross, since you're seeing the return there, I'll let you close that out.
Okay. Trying to remember the number of nursing folks at the beginning. Here you can see interesting results. I wish we could flesh out these others a little bit more.
So very good. Well, we can see that we have a variety of other types of learners. And the other thing just from this slide is that in the 30 years or so that I've taught with Harvey, I've probably taught sessions involving all of these different groups, certainly a large amount for nursing, but also paramedics, respiratory therapists, and the like. On the next slide, I'll talk a little bit about some of the work that we did about 10 years ago, where we had gathered together nursing representatives from 8 different programs around the country, both associate degree, baccalaureate degree, and master's degree nursing programs, and identified within the existing Harvey curriculum what would be content particularly useful for nursing. And as it turned out, that content was also useful and very easily adapted to the other health professions. Just as we had for the original Harvey and UMedic instruction, we developed a learner manual and instructor guide that would go with this. And included in that guide are some sample examples, of how you might want to put that together for your particular curriculum. But the thing I would emphasize is that the content here is readily kind of moldable to any way in which you want to teach cardiopulmonary assessment. So what we identified here was kind of the big 12 findings that we thought all students would need to know. And we further divided that sort of in basic and advanced content. On the next slide here, you'll see just a quick example of what the content looks like in the manuals. Again, 12 different core findings. All of this was structured around a very orderly, systematic approach to patients. And one of the things that Dr. Gordon had in mind in building Harvey was really creating the ability to replicate doing bedside teaching. If you've been involved in clinical education of any sort, you know that that is a very rich source of education, but the problem is you don't always have access to the types of patients you want to teach about. Well, with Harvey, you have any kind of patient you want right there at your fingertips. So in emphasizing this systematic, orderly approach, we would approach each case in the way that you would approach the patient in a clinical setting. So all of the cases in the curriculum are designed around a case-based teaching format. In the next slide here, one of the things that we did after putting together the curriculum was to put together a study. This was led by Pam Jeffries, who's now Dean at School of Nursing at George Washington. And we put together a simple study that involved a pre-test, a training intervention with Harvey, and then a post-test. And the idea of the study was to sort of validate the curriculum content that we had pulled together. On the next slide here, you will see that in terms of some of the outcomes we were measuring, we were looking at cognitive knowledge, skills demonstration, self-efficacy of the learners, their satisfaction with this learning format, as well as the satisfaction of the instructors in using this type of training, and then also a student log that they could record their individual practice times. One thing I would note about this study is that it would be very easy for any of you to replicate if you wanted to do a similar study with students that you work with. Maybe it's physical therapy, maybe it's respiratory therapy, and we would certainly be glad to assist you. So the overall approach to this with those outcomes in mind was to give a pretest, both a written and a skills pretest. We did the education intervention, which was a lecture followed by small group-led instructor sessions, followed by individual student sessions, and then a post-test of each of those areas. Thank you, Ross, for going back to that. And so real quickly, I won't go through all of the outcomes, but just two kind of highlights. One was we saw a significant increase in the knowledge base for all of the students and saw an even more impressive increase in their skills assessment. The thing most notable by students and faculty was the fact that just by becoming more systematic in their approach, the students were far more efficient at not only conducting the assessment, but being able to interpret the findings. We replicated this same study both with entry-level pre-licensure nurses, RNs, and then also with advanced practice nurses from all of the advanced practice specialties. And on the next slide here, I'll just mention some of the different ways that I've used Harvey in different kinds of teaching, certainly interactive demonstration, discussion kinds of teaching, whether that's in front of a large class of 50 or 100 students, or if it's a small group of 12 or 16. But the idea is you really want to keep it interactive, and that was one of the pieces that Ross had highlighted earlier. So just by exchanging back and forth with the students, Harvey, and your discussion, you can lead a very engaged interactive format. More recently, we've been doing that with Zoom, and again, have found that just as equally effective. When you have the opportunity then for small group sessions, again, these can be instructor-led, these could be led by a teaching assistant if you have that, but in a number of formats, it gives students the opportunity then to get hands-on practice and going through the skills. And again, the thing we emphasized was going through the assessment in a systematic, orderly fashion. And then finally, the last slide, the thing that I like to use increasingly is a peer-to-peer, a team of two people going through and practicing together. We're starting to see in some of the simulation literature information to suggest that when students pair up in teams and practice, it drives the learning forward for both groups. They're a little bit more motivated, but more importantly, they're accomplishing the task a little bit quicker and reaching a little bit higher level of attainment, probably because they're challenging each other and sort of testing each other on the content that they don't know well enough. We have a tendency to repeat the things we know well. So in terms of a learning strategy, the peer-to-peer approach works well. The same thing if you want to assess in that format. I will often assess the team groups together, and if one doesn't pass, they both have to go back and work on the remediation together. So I find it's a really effective learning strategy to use, and Harvey's very well adapted to that. In the next slide here, I'll also mention how I've been able to accommodate teaching with Harvey, where sometimes the number of learners outnumber the resources I have or the number of faculty. This might be the case if you're teaching like a health assessment course that sometimes gets scheduled in the lab at a little bit larger size than you might do for other kinds of simulation. So one of the things I've done is to break up the different components of what we're trying to teach We're certainly trying to focus on history and physical assessment, but I'll create a larger activity for all of the students. Maybe it's a review of anatomy and physiology related to cardiac. Maybe I want to incorporate a review of medication, something like that. But I'll use that larger activity in a large room and let the students get started on that. And I'll take the first student or two students and send them into a separate room where they'll do the assessment of the patient, and then set a certain time limit to that, 5 minutes, 10 minutes, whatever I want to use, and then move that first group of students onto the next room in which they will examine Harvey based on that same case. And they will then sequentially just keep moving from the physical exam to then going into another room where they can give a verbal report. Again, a lot of times our clinical instructors or preceptors sometimes complain that students don't really know how to give an oral report of the patient's findings. So we'll allow them to either give a report on video or give a report to another instructor, and then follow that up as well with another station where they can document. As that group, that first group that starts, as they keep moving along, I keep feeding in another group behind them. So it's an efficient way for me to sort of be able to teach 4 or 5 different components at once, where it's only me as the instructor really just coordinating the logistics. So again, we've set the stage for this in the lectures, set the stage for the session, doing a pre-brief, and then also do a post follow-up brief with that at the end. But we find that it's a very effective way of sort of engaging students in an active way of learning, as opposed to just trying to take the entire group, do more of a lecture, and have a lot of people just sort of sitting around. So it's a very active way for engagement. And then with that, Ross, I'll turn it back to you so we can open up. I do apologize, I forgot that I did add one more slide here, and that was just a reminder that we do have with the Harvey curriculum another manual that incorporates cases for standardized patients. This gives you 10 different scenarios and all of the scripts for those standardized patients. And I should mention too that as I was talking about the nursing curriculum where we identified the Big 12 findings, if you or your students want to incorporate other content, you still have access to all of the other UMedic programs. So if you wanted to have pediatrics or other areas, you would certainly have access to pull all of that together. And now I can go to Ross and we can open it up. We have just a few minutes remaining for some questions.
Thank you so much, Nina and Jeff. I've been looking in the Q&A pane here. We don't have any questions that have been asked up till now, but at this point, if anyone has questions for any of the panel, please do use the Q&A function. And we'll try to, oh, I see that there were 2 that were answered. They're more technical things, I see. At this point, we could also use just the straight chat. I didn't know if there would be a lot of back and forth there, and sometimes you lose track of questions, but feel free to use either forum for any questions to Nina, Jeff, or myself.
So Ross, while you're waiting for that, let me ask you, I see nowadays a lot of apps and programs and kind of quick reference features available as like a quick review of heart sounds on your phone. What are the advantages and what are the disadvantages of that? Is that a good way for initial training?
Well, again, you did a great job of highlighting the importance of the orderly approach, right? And so that really jumps to kind of the final step in the way that we like to teach physical examination, cardiac physical examination. So that's just for the listening skills. And then sometimes that's to the detriment, or students then learn to ignore or not, look at the arterial pulse, the chest wall, and so forth. So it has its place, and for sure, in terms of just-in-time training and as a refresher, I think that's great. But I do believe that a patient-focused approach at the beginning will get them further along, as you mentioned. All right, I'm seeing we're right at 1 o'clock. We're very sensitive to people's busy schedules, and we don't want to keep people over time. If there are no questions right now, let me go to the next slide, which has contact emails for the three of us on the panel. Let you jot those down. Feel free, please, to sometimes after you just close out the webinar and then you think of something. So don't hesitate to reach out to any of us, and we'll be happy to try to answer any of your questions. Of course, you can also contact your local Laerdal colleague as well, and they can connect you with us if you lose our email addresses. Finally, the website for the Gordon Center is listed here. Happen to be in South Florida at any time, we welcome visits to our center. And again, thank you so much for everyone's time and attention. We hope that this has been informative. Stay well, everyone, in these challenging times, and we hope to be with you again before too long and have another webinar. Thanks so much. Bye-bye.
Thank you.